Let me start recording. In the previous lesson, we have covered about thromboembolism. So today, I'm going to take you through about rheumatic heart disease. Maybe if we have time, we're going to start even a stroke. Okay, so what do you understand when we say rheumatic fever and rheumatic heart disease? What do you understand? Anyone who is volunteer to try?
Does it have anything to do with group B streptococcal infection? Group A streptococcal infection?
Yeah, yes, it is something related to Group A. But by the way, I was wondering, have you covered this topic maybe in somewhere in the infectious disease part in the previous semester?
We've talked about rheumatic heart disease briefly, but as a whole topic, not really.
Okay, that is why normally I just decided like before I normally included this one under cardiovascular disorder, but infective endocarditis normally should be in the infectious disease. But because this one is not really, it is just caused by the infection, but it is not like due to direct invasion of the microorganism. That is why I just decided this is the relevant section to discuss. So you can see the videos when you get time. So that what is objectives at the end of the session? So at the end of the session, you need to define what is RHD and what is acute rheumatic fever, and you need to define or discuss briefly the pathogenesis of RHD and ARF. You need to outline the diagnostic modalities, and of course, you need to know about the management and prevention of RHD, and you need to discuss as the complications of RHD as well as their management. So these are the objectives for this session. So as much as possible, try to actively participate in the session. So when you say acute rheumatic fever, it is an immunological mediated inflammatory reaction which occur as a result of group A streptococcal pharyngeal infection, specifically from group A streptococcal microorganisms. Streptococcal pathogens are the one that is responsible for this autoimmune reaction. Then this ARF involves multi-organs, but principally the heart, joint, brain, and cutaneous and subcutaneous tissues, and it is one of the most important preventable cause of cardiac disease. And of course, this condition has no lasting damage. Despite the brain, joints, and the skin are involved, there is no permanent damage on the brain on those organs. But there is a persistent heart damage, which is known as rheumatic heart disease. So repeated acute rheumatic heart failure is acute rheumatic fever is responsible for the occurrence of the chronic complication that is known as rheumatic heart disease, which is characterized by valvular involvement. So when you look at this condition, it is the most common sequel of RF is rheumatic heart disease, and it usually occurs like 10 to 20 years after the original illness. So most of the time, the incidence or the occurrence of this condition is merely occur after 10 to 12 years after the original illness, and it is one of the most common acquired valvular disease globally. So even in our setup, this condition is really very common, but most of the patients, they came up with the diagnosis of RHD after they developed valvular problem. Then remember, in acute rheumatic fever, the heart valves are the one which is majorly involved. So mitral valves are the most commonly affected valves when a patient is having acute rheumatic fever, followed by aortic valves, tricuspid, and pulmonary valves. So generally, the mitral valve stenosis and regurgitation is the most common problem after a single or repeated attack of acute rheumatic fever. So because of this reason, there is a need of even doing the echocardiogram to assess whether the valve is normal or not after the attack. Then when you look at the epidemiology of this condition, it is very common in developing countries who is living under poverty. Yeah, this is because recurrent infection, recurrent infection is very common, and the habit of actually is overcrowding is very common in the African setting. So the possibility of having infection is actually very high. And this condition can occur at any age, but mostly it is very common in children between the age of 5 to 15 years old, according to the epidemiological studies. Then, when you look at the prevalence, the episode is very unlikely. It is only like below around 5% when like below a children age less than 5 years. That is the most common issue. So it is not very common, like less than 5 years. Okay, then when you look at the global epidemiology, you can actually even the new incidences and the diseases globally that can occur every year. So every year, this number of new cases and this number of diseases can actually occur because of rheumatic fever or RHD globally. But it is very common, specifically it is one of the most common cause of cardiovascular disease in the developing countries, as I mentioned before. Then what causes rheumatic heart disease and what causes rheumatic fever? So the whole idea is there is an infection. So when there is an infection due to a group A streptococcal organism, what will happen? Then antibody will be produced to fight against infection. So this can cause inflammatory reaction that can actually cause destruction of the organs I mentioned before, like the heart, the brain, the skin, and the joints. So the body normally produces antibodies to fight the microorganism, but because of similarities, in the cell wall component of the microorganisms and some of the organs, what will happen? There is a possibility of cross-reactivity. That means this cross-reactivity means like it can actually the antibodies will not differentiate between the normal, the microorganisms, cellular component, and the human target organ, mainly the cardiac valves. So rheumatic fever only develops in children and adolescents following this infection, which is actually very common. So mostly it is usually occur after streptococcal pharyngitis infection that can initiate or reactivate rheumatic fever. Then what are the possible risk factors? So risk factors is poverty, overcrowding, maybe the autoimmune condition of the patient and the age of the patient, very common in children. Then when you look at the pathogenesis of this condition, remember there is no direct invasion to the tissue by the microorganism. It only affects what? The pharyngitis. But what will happen when antibodies developed against the antigen, that means the cell wall of the microorganism, then this one can actually affect the other organ because of cross-reactivity. Then this one is a delayed type of sequence because this reaction will not occur immediately. It usually happens after some time. Then the antibodies can cross-react when the body is developing antibodies to the cellular component of the microorganism. The antibodies can actually cross-react to the human tissues because of antigenic similarity between the streptococcal component and the human connective tissues. We call it molecular mimicry. So this molecular mimicry is because of similarities in amino acid sequence that is similar to the gas and the human tissue. So because of this molecular mimicry, there is a possibility of cross-reactivity. And most of the time, rheumatic heart failure or rheumatic fever normally precedes the pharyngeal infection like 2 to 6 weeks. So the patient is most likely having infection of pharyngitis for 2 to 6 weeks. Then after that, this antigen antibody reaction can actually causes the damage. So the antibodies against the M proteins of the microorganism can cross-react with the glycoprotein in the heart, joints, and other tissues. That is why the antibodies produced against M protein can distract the heart valves, can distract the joints, and can also affect the brain. That is a major problem with this condition. So, in short, acute rheumatic fever is an immune-mediated reaction as a result of streptococcal infection. Okay, good. For example, when you look at normally the specific antibodies with its cross-reactivity, like the cell wall of the polysaccharide, antibodies against the cell wall of the polysaccharide can cross-react against the cardiac valve. So any antibodies that is produced to distract the cell wall component of the microorganism can affect the heart valves. The antibodies that is produced against the capsule of the microorganism can cross-react with the human joints. Then also the antibodies that is produced against the membrane antigen of the microorganism can actually cross-react the smooth tissues, including the brain tissue. So in such a way, they can actually produce significant clinical damage to the target organ. So this is normally the summary of, this is the summary of this is normally the summary of the pathogenesis mechanism. So you can actually even see cross-reactivity causes specific destruction to the target organ. So you can see damage to the heart, to the brain, joints, and to the skin. Okay, I think this one you can read, and even this one is still just normally explanation how this condition can actually affect. Okay, then having said this much about, let me talk about the clinical presentations of acute rheumatic fever. Acute rheumatic fever, ARF. So I have already said about the major organs are the brain, the heart, the joints, heart, joints, and of course it can also involve skin. So when you look at the major manifestation of this condition, it relies on these areas. So the clinical features are classified into two broad categories: the major manifestation and the minor manifestations of acute rheumatic fever. So what are the major manifestations? The major manifestations are carditis and valvulitis, inflammation of the layers of the cardiac tissues and the valves. Arthritis, so mostly the arthritis are usually migratory in nature, but predominantly involving the large joints. So you can actually even see this condition or the arthritis are usually migratory in nature. That means if it involves normal today, the knee joints on the other day, on the next day, it actually, that pain will resolve it and it goes to maybe the hip joint or maybe other joints. So that is why it is known as migratory polyarthritis. Then because of CNS involvement, it can actually cause abnormal involuntary movement because of inflammatory condition or the motor neuron. Then it can cause subcutaneous nodules on the skin, mostly in the bony areas, and it can also cause even erythema marginatum, like a kind of ring lesion at the backs in the trunk areas as well as in the extremities. So we call them major manifestation. So what are the minor manifestation? Arthralgia will be occur. There is a joint pain. Then the patient can have fever because of inflammatory reaction. Then, as the result of the inflammation, there is high probability of elevation of inflammatory marker such as ASR and C-reactive protein, CRP. So those are acute phase inflammatory markers. Then, as the result of damage of the heart valve, the probability of prolonged PR interval on ECG. So we call them minor manifestation. So let us see in detail about the clinical presentations on each component, specifically the major manifestation. So arthritis is the earliest and most common symptoms of acute renal failure. Sorry, not acute rheumatic fever. So this is very common and it is the earliest symptoms and it is very commonly seen in majority of the patient. So mostly it involves inflammatory reaction to several joints in a short period of time. Each joint can be affected, which ranges from few days up to several weeks. Then after that, it will migrate to another joint. So the knee, ankle, and elbow and wrist are the most commonly affected joints that is involved in the ARF. Of course, due to the inflammatory reaction, migratory arthritis can be subsided with NSAID treatment. Then the next condition is Sydenham chorea. So this one is usually occur as late as 8 months of post-infection and characterized by series of abrupt involuntary movement, as you can see from the diagram. So as a result, even there is a possibility of muscular weakness and emotional liability can also be present. Okay, then the next major manifestation is erythema marginatum. So this is characterized by a pink, faintly red, and non-pruritic rash involving the trunk and extremities, but not the face. As you can see, it seems like a lesion of Tinea versicolor. Here you can see pink and faintly red rash on the extremities. We call it erythema marginatum. Then the individual lesion can appear, disappear, maybe reappear. So this feature is really very common. Okay, so this is what you call erythema marginatum due to this condition. The next step is because of skin involvement, it can cause painless, usually symmetrical lesion that can vary in size, especially located on the bony surface, which is very common. So can you see normally the nodules? Those are the nodules due to acute rheumatic fever. So it is mostly common in symmetrical manner in these areas. Okay, so it occur in only in 5% of the patients. So it is not as such common like that of migratory polyarthritis, but it is very common. It only occur in 5% of the population. Okay, so this is something you need to give emphasis, which is very important. Then the next step is the possibility of having carditis. So remember, carditis is like the major problem with ARF, which can actually cause valvular heart disease. So inflammation, it is known as inflammation of the heart and its surrounding structure, and mostly it is presented as pancarditis. So pancarditis is referring to the involvement of all layers of the heart. Remember, the heart chamber has 3 layers. The outer layer is the epicardium. This one is the epicardium. Then the middle layer is myocardium. Then the innermost layer is known as endocardium. So all the 3 layers of the heart can be inflamed because of this autoimmune reaction. Then when you look at in terms of prevalence, like 30 to 70% of the patients with ARF have cardiac involvement with their first attack. So if they do have first attack, like in majority of the patient, like 30 to 70% of the patient can have carditis. So this is the only manifestations of RH or ARF that leaves permanent damage to the organ. But the other manifestations can actually, they are self-limiting. Like after treatment, they can be resolved. But this one can cause permanent damage. That is why, and that is why we need to give due attention when a patient is having acute rheumatic fever. Then, how do we diagnose this condition? The Bence-Jones criteria is the one that is commonly used in the diagnosis of acute rheumatic fever. So, what is required for the diagnosis? So, for the diagnosis, what is required is to have the patient need to have only two major manifestation, what we have discussed before, or one major plus two minor is sufficient for diagnosis for an initial episode of ARF in a patient with evidence of preceding gas infection. So if a patient is having preceding group A, if we need to have what? Like what? Two major plus evidence of preceding gas infection, or one major plus two minor plus evidence of gas infection is required. But if a patient is having a history of acute rheumatic fever from the history, two major and one major plus two minor or three minor manifestations are sufficient for diagnosis of recurrent ARF. In this context, we don't need to do a test to check whether the patient is having gas or not. Yeah, because already we do have the information, the patient has having history of ARF. Then this diagram is just a summary of the modified Jones criteria for diagnosis of acute rheumatic fever. You can see the major criteria and the minor criteria. So I have already mentioned about the diagnostic modalities. So how do we check whether the patient is having evidence of group A streptococcal infection? You can do throat culture or maybe do antigen test, or alternatively, you can do antibody titer test. Look at the presence of antibodies against that microbial infection. Those are like the lab parameters. So how do we assess whether the patient is having prior episode of group A beta hemolytic infection? We can do throat culture, we can do antigen test, we can do antibody titer. Those are the anti-streptolysin, anti-deoxyribonuclease. I hope you have covered it in microbiology for sure. So those are the common antibody titer that can be that is useful to assess whether the patient is having gas infection or not. So this is all about the diagnostic criteria. So the next step is, how do we treat? Now, based on the modified Bence-Jones criteria, we do have the information the patient is actually having acute rheumatic fever, and how do we treat the patient? So what is the goal of therapy in the first case? The goal of therapy in this case is symptomatic relief of acute manifestation, then eradication of group A beta hemolytic microorganism, of course, finally give prophylaxis to prevent future infection. So the first thing is normally relieve the acute disease manifestation, then after that, eradication of the microorganism, and finally, prevention of recurrent attack. Because of this goal, our treatment includes anti-streptococcal therapy, symptomatic relief with anti-inflammatory drugs, and antibiotic prophylaxis for secondary prevention, and supportive care is our treatment options. So what are the major primary treatment in the treatment? What are the primary treatment for to eradicate this microorganism. Remember, this microorganism is a gram-positive infection. So, penicillin class of drugs they are efficient enough to distract gram-positive microorganisms like the penicillin, indentin penicillin, and penicillin V. They are sufficient to distract normally the microorganism. So, how do we treat Benzant? If we do have benzathine penicillin, we can give this much dose. IM start is sufficient to treat this condition. Or alternatively, we can use the oral penicillin B, 250 BD for 10 days are sufficient. But in case if a patient is allergic to penicillin class of drugs, okay, we can use the erythromycin, the macrolide can be used. But by the way, let me ask you one question. Maybe it is pharmacology. So why a patient becomes allergic for penicillin? Why few patients are allergic to penicillin? I'm waiting the answer. Why patients are allergic to penicillin?
Because of the sulfur component in penicillin.
Okay, because of the sulfur component in penicillin. Okay, good observation. Any other? Any other? Okay, good. Okay. Remember, what is the metabolic product of penicillin?
Penicilloic acid.
So, okay, good. So, the metabolic products of penicillin is actually penicillic acid. So, this penicillic acid is serves as a haptin molecule. You know haptin? Those are actually it combined by binding with the cellular component of the body. They can cause allergic reaction for two patients. So allergic reaction due to penicillin is because of the penicillic acid. So this can serve as a haptin, which is antigenic when it combines with other intracellular component. So that is why allergic reaction is very common. So if a patient is allergic to penicillin, is there anyone who is allergic to penicillin class of drugs? Is there anyone who came across allergic reaction due to penicillin? So you didn't came across a patient. Okay. So it can cause like from a small mild rash to severe anaphylactic shock. So this is one thing to note. So we can use macrolides. Like the macrolides erythromycins are very effective in terms of managing gram-positive infection. Okay, so this is how we're treating we're treating the primary infection to eradicate the microorganism. Then the next step is we need to actually relieve pain associated with the carditis. So the use of anti-inflammatory drugs. So for mild condition, maybe we can use aspirin. Then for moderate to severe condition, we can use strong anti-inflammatory medication. Those are the steroidal anti-inflammatory drugs. So you can see for 2 weeks, this is commonly used to manage carditis. So we can use either a steroid or depending on the severity. If it is severe to moderate, we can use steroids. Okay, then the next step after managing the inflammatory reaction is now we have already eradicated the microorganism with 10 days of treatment or start dose of benzathine penicillin. The next step is considering prophylactics for secondary prevention. So what is the essence of secondary prevention is, if we don't give secondary prevention, what will happen? The patient can have recurrent infection. So this recurrent infection can really significantly damage what? The heart valves, and ultimately the patient will end up having heart failure. So that is why secondary prevention is part of the strategy in the management of this condition. So you have to know. Benzantine penicillin G or can be given 1.2 million every 4 weeks as a prophylaxis, or we can still use penicillin V to 50 milligram twice daily, can be considered if a patient is allergic, as I mentioned before, azithromycin can be given. Then this is summary of the dosing schedule of this drug. You can see if the weight of the patient is above 27 kg, we can use 1.2 million. This is just a start dose. Then if it is less than 27 kg, we can actually still use start dose. Then remember, for children, we use 250. For adult, we use normally 500 milligram for 10 days. But if a patient is allergic, we do have different options, like the first generation cephalosporin can also be considered in the management. Then secondary prevention, like in the prevention of recurrent attack, this is whereby we're going to consider the same doses. I think there is no difference in the doses. Whatever is normally the weight, so 250 and 250 can be considered. Then the next step is, how long do we give prophylaxis for secondary prevention? So the recommendation, the duration of treatment is guided by the clinical condition of the patient. For example, if a patient is having rheumatic fever but no carditis, 5 years prophylaxis is commonly recommended. So if you give them treatment for 5 years, it is actually sufficient. If you give them treatment for 5 years, it is actually sufficient. So whichever longer, maybe until the age of 21, we can consider to give this prophylaxis. The next step is, if a patient is having rheumatic fever with carditis, but no residual heart disease, we can consider 10 years prophylaxis is recommended. So 10 years or well into adulthood, whichever longer can work. If a patient is having rheumatic fever with carditis with residual heart disease, at least for 10 years and at least until the age of 40 is usually recommended. So the clinical condition of the patient is, it is the clinical condition of the patient what guides you the duration of antimicrobial prophylaxis. So those are very key information. So generally speaking, the lifelong treatment is usually recommended. Okay, then the next step is, what is the role of bed rest and supportive therapy? So bed rest is very important because of the joint pain occur in 80% of the population. You need to allow the patient to have bed rest and residual and reduces cardiac workload. So because of the workload on the heart is very high, then you normally recommend bed rest is the most common conditioning. So you allow them, the patient. So what guides you is actually the inflammatory markers as well as the patient condition. So generally speaking, the patient can return to normal physical activity, but not very strong exercise to avoid those patients who had carditis. So because of the workload on that will be high when we do very strenuous exercise, is generally avoided in this patient is having carditis. Then how do we treat Pseudomonas chorea in a patient with ARF, mostly Pseudomonas chorea is self-limited as long as we eradicate microorganism. But of course, if the patient is having that dance-like movement, maybe we can initiate corticosteroids. But remember, in case of Pseudomonas chorea, there is also emotional lability. Because of that reason, the patient can have psychotic feature. So in such a scenario, maybe we can consider the use of antipsychotics. But most of the time, as I said, Pseudomonas chorea does not require treatment. So this is very important information to note. Then finally, how do we treat, or what is rheumatic heart disease? So this is all about the acute condition, which is known as acute rheumatic fever. So you have to know the criteria for the diagnosis, and you have to know the clinical presentation, and you have to know how we're treating this condition. So that is the whole idea of the session. And now, let me take you about rheumatic heart disease. So what is rheumatic heart disease? So maybe in summary, like before I go to the next session, then let me ask, Oliver. Oliver, can you hear?
Yes, sir. I can hear you.
Okay. So what did you learn? What did you learn so far?
About acute rheumatic fever, which is an immunologically mediated disease, majorly caused by group A streptococcus, group A beta hemolytic streptococcal pharyngitis. Yeah. The major manifestations, we have carditis. This is inflammation of the heart and the valves. We have arthritis. CNS involvement, such as Sidon, Dance, St. Virtue's Dance. We have subcutaneous nodules and erythema marginatum. Then the diagnosis, it is based on John's criteria. And then we went to the treatment. We have primary anti-streptococcal therapy, whereby we use benzathine penicillin or penicillin V, where if one is allergic to penicillin, we can use macrolides such as erythromycin.
Okay, good. Thank you. So this is a good summary. So now, let me take you through about rheumatic heart disease. So rheumatic heart disease is one of the most serious complications associated with acute rheumatic fever. So mostly occur 10 to 20 years after the original illness. So this is how it occurs. And then remember, this is one of the most common causes of acquired valvular disease globally. And most of the time, like if a patient is having rheumatic heart failure with carditis, like more than 50% of the patient will develop valvular disease if they do have this manifestation during the acute episode. So if you can see in terms of valvular involvement, the mitral valve is involved in 90% of the patient. So this is the most commonly affected valves. So different scholars normally said a lot of things about why this condition is mainly affecting the mitral valves, why not the pulmonary valve. In fact, pulmonary valve is the least affected valve due to rheumatic heart disease. So there is a lot of actual controversies, but mostly they are saying because there is a lot of pressure, we call it the shear stress on the mitral valves, the result of the contraction of the left ventricle. So a slight damage can actually worsen the condition. So because of high shear stress on that area, that is why the mitral valves are commonly affected. So most of the scholars are actually saying this is that is why this is the most common reason that why mitral valves are commonly affected. Then the lesion can develop after 10 to 20 years in the Western countries, but much earlier in developing countries, like because of the lack of adequate treatment. So like, I don't know how many people normally go and see the physician for pharyngitis. Even no one knows normally whether they actually rely it like a common cold. Yeah, if they do have a sore throat, which is known as pharyngitis. So really, like this is really given to consideration, especially in children with that age group. It is really very important if they complain pharyngitis, they do have some sore throat. It is good to see to undergo screening so that they can identify whether it is microbial infection or not. So in the chronic rheumatic heart disease, it is a condition that affects the heart valves, which causes permanent damage by rheumatic rheumatic fever. Then I think I have already said most of the information. It is associated with this infection. It is just an immune response, and single or even single infection can cause rheumatic fever. So results from a single or repeated infection of rheumatic fever that can produce rigidity and deformity of the valves. So it is caused by an episode or a recurrent episode of ARF, as I mentioned before, because the heart has become inflamed, the valves are stretched, and normal blood flow is interrupted. This ultimately causes what? A deformity of the valves. So when there is a recurrent ARF, it can cause further damage leading to worsening of the rheumatic heart disease. That is why recurrence treatment is really, that is why adequate prophylaxis should be given after the initial diagnosis to prevent what? To prevent a worsening of the valvular damage. That is another point, and as I mentioned before, like that of acute condition, this condition is very common in developing countries. And you can see about the global mortality rate of this condition is really very high. So what causes rheumatic heart disease is self-explanatory, as I said before. So this is just because of cross-reactivity. So this cross-reactivity can cause damage of the valves. Then after that, this damage can cause narrowing or leaking of the heart valves. Remember, if the heart valve is narrowed, means there is actually, it affects the normal blood flow in the heart valves. So the heart will not pump properly. That's the major problem, and most likely it takes several years to develop, and it can cause a risk of heart failure. So majority of the patients are interacted even is normally for RHD patients, they normally develop with heart failure. So in our setting, mostly they came with like a diagnosis of heart failure due to rheumatic heart disease. So this is the major problem that is affecting our children. Then who is at risk? Of course, if a patient is not treated very well for strep infection, and this can increase rheumatic heart disease. If a patient is actually having a children who get a repeated strep infection, they are more at risk of having the RHD, the chronic condition. Then what are the implications of RHD on the heart valves? So when you look at the negative impacts of the valves, as you can see from the diagram, this is the normal valves, and this one is regurgitation. Remember, regurgitation means the backflow of blood. Yes, like this one, in principle, when the valves are contracted, this valve is supposed to be closed, but because of damage and because the valves are become leaky, there is like improper closure, then you can see about the backflow of blood on this. In this condition, we call it regurgitation. So, generally speaking, RHD can cause stenosis and regurgitation of the valves. So, you can see about the effect is very significant with mitral and aortic valves. That is why respective regurgitation and stenosis will happen, and this ultimately affects the cardiac output. So those are the general lesions that can happen as a result of RHD. Then, what are the clinical features of rheumatic heart disease? So what are the clinical features of rheumatic heart disease? So if you look at the general features of rheumatic heart disease, there is shortness of breath, there is chest pain and swelling. But mostly, the clinical picture will depend on the degree of valvular damage, because it is a major cause of heart failure as the result of stenosis of the valves and regurgitation of the valves. The patient can have shortness of breath, chest pain, and swelling. Yeah, this is mainly those are the major clinical features of heart failure. So the patient will have signs of heart failure. Then how do we diagnose? How do we diagnose this condition? Most importantly, medical history is very important. So we need to assess whether the patient was having previous diagnosis of rheumatic heart disease. That is very, very important. Then the next thing is we need to check the heart valves for any damage. So mostly it is very useful test for finding out if RHD is present or not. Remember, echocardiogram will tell us anatomical abnormalities on the heart muscle as well as the heart valves. So that is why this echo is really a very important test to find out whether the patient is having RHD or not. Then, presence of murmurs on auscultation. If you remember, in the previous semester, we have mentioned about some of the physical, like the physical diagnosis, physical investigation modalities is auscultation. So, if you see a murmur, those are abnormal heart sounds. I wish you could have seen on the live patient. Murmurs are abnormal heart sounds that can be present on auscultation. So if there is a murmurs, that is also an indicator there is some problem in the heart valves. Then chest X-ray will tell us whether there is enlargement of the cardiac tissues or fluid on the lungs. Yes, that is something you need to note. Then ECG will tell you whether there is enlargement of the chambers or the heart chambers are enlarged, or whether there is abnormalities in the cardiac rhythm. If you remember about the P mitrally and P pulmonally, I mentioned something about this one. The P mitrally means the P wave of the ECG becomes M-shaped. It becomes like this. It will tell you that there is what? Enlargement of the left atrium. That is how you normally know. Okay, so this is, we call it the this is normally P mitrally. Yeah, so it becomes normally M-shaped. That will give you an idea. The left atrium is enlarged. But if the P wave is actually peaked, it means we call it P pulmonally. So this is an indicator that there is right atrium enlargement or hypertrophy. So from the ECG, when you can get a lot of information, including the abnormal heart rhythm. So those are the diagnostic approaches that should be considered as long as this condition is considered. Then how do we treat this condition? So maybe let me jog your memories. So how do you, what do you think about the treatment modalities for this patient? How do we treat? How do we treat anyone, Saida?
Yes, sir.
So what do you think? How do you think? Did you like capture some of the important information about RHD? So how do you treat this condition?
Maybe we can use diuretics for fluid retention.
Okay, good. Diuretics can be considered if there is a fluid retention, okay, good, in the lung, or if there is a fluid in the extremities. Okay, that is one possible option. Any other option? Any other person? Tanzil?
You can give beta blockers
Why you give beta blockers?
to control to slow down the heart, to control it.
So that you will reduce workload of the heart. Okay, good. Yeah, that is one strategy. Okay, good. Then Rodney, C11. Okay, Vivian. Vivian, can you try? Okay, good. I think because of time, we need to proceed. The treatment of RHD will depend on the extent of damage on the heart valves. Maybe in severe cases, if there is what? If there is severe damage on the heart valves, maybe surgery should be considered to replace the valves. So mostly to replace the badly damaged valves, maybe repair surgery. So the cardiac surgeon will do the surgery. But generally speaking, the best treatment option for RHDs prevent further rheumatic fever. That is the most important thing. So as I mentioned before, in case if the patient developed heart failure, so what do you understand by the term congestive heart failure? CT.
There's accumulation of fluids in the heart and in the lung because it's
Okay.
not being controlled properly.
Okay, good. So when you say congestive, that means there is fluid accumulation. Yes. But heart failure can occur without fluid accumulation, but they have to know. So in case if a patient is having congestive heart failure, now you can consider the basic treatment regimen, what we have discussed early in the beginning of the semester, about the heart failure management, the ACE inhibitor, the diuretics, the vasodilators, and it's the beta blockers, of course, the digoxin. Those inotropic agents can also be considered in advanced setting. So if a patient is having this condition, we can actually consider. But generally speaking, in case of chronic rheumatic disease, mostly the treatment will be depending on the condition. For example, if a patient is having mitral regurgitation, maybe if there is severe regurgitation, surgery can be recommended for repairing of the valves. So that is the role of the surgeon. But medically or using pharmacological molecule, we can use diuretics and ACE inhibitors if the patient will have heart failure. Then in case of stenosis, those are some of the complications. In case of stenosis, atrial fibrillation is very common. So maybe we can use drugs to control the rate, and we can use drugs to control the risk of thromboembolism, such as warfarin can be considered. Maybe valvular replacement can also be considered in severe conditions. So for this condition, the only strategies we're having is just symptomatic management. Maybe valvular replacement can actually restore the condition, but if someone is having replaced valves, they're supposed to be on long-term anticoagulants, because prostate valves are a good opportunity for the occurrence of what? The occurrence of clots in the heart. So that's the major problem. So finally, what are the major complications of rheumatic heart disease? So if someone is having RHD, means there is what? A valvular damage. So if the valve is damaged, it can cause heart failure. Yes, this one is occur because of narrowing or leaking of the heart valves. And of course, when there is a damage on the valve, this is a good opportunity for the microorganism to produce vegetation at the site of the cardiac tissue. So bacterial endocarditis are common. It is one of the complications of this condition. But if the valve is normal, by the way, the probability is very minimal. Then finally, ruptured heart valves are also another complication when someone is having RHD. So this is all about this condition. Maybe now, let me receive any questions or any misunderstanding. You can actually raise the issue so that we can discuss. Any issues?